This conference will now be recorded.
Good morning. My name is Rebecca Clark-Bash, and I'm going to be talking about the preparation path for the Registry in Evoked Potentials and certification in neurophysiologic interoperative monitoring. My background, I started as an EEG tech in Chicago and later went on to get my EP, my CLTM epilepsy boards, my CNIM, my interoperative boards. I am also a fellow of the ASNM and of ASSET. I have previous experience on the ASNM Board of Trustees, the ASSET Board of Trustees, and I love to have fun, and I hope we do that today, even though I can't be with you in person. In the event that you have any questions regarding this lecture, or you'd like some of the handouts that I'm going to talk about this morning, please feel free to email me at knowledgepluspro@gmail.com. That's knowledgepluspro@gmail.com. So I want to talk about some of the handouts that I can make available to you that are going to enhance or expedite your study experience. And again, many of these are available online, but I can send them to you as one big group file set. So the first thing, the most important thing when you begin your journey to take any ABRET exam is to access the American Clinical Neurophysiology Society's guidelines on how to perform these tests. Now, for clinical evoked potentials, you will access guideline 9A through 9D. For interop, you'll have to memorize the interoperative guidelines, but also about 50 questions on the test are on the clinical environment. So you'll have to become familiar with how to do clinical evoked potentials as well via the guidelines. Now, the only guideline that does not apply to the CNIM exam is the visual evoked potential guideline. And then guideline 11A through 11C and guideline 15, those are the interoperative monitoring guidelines. Now you'll notice there's no guideline interoperatively for visual evoked potentials because it's not a sensitive tool to detect postoperative function. Now you'll also notice here guideline 15 is the guideline for transcranial motor evoked potentials. And this guideline was really eagerly awaited as we have three different schools of thought basically on the method and the interpretation alarm criteria. So it consists of Dr. Delitis, Dr. Hausman, and Dr. Calancy. And when this guideline was published, it was hoped that they would have a direction amongst the three methods. It was hoped that there would be direction as to what is best or what is standard, and that didn't happen. What this guideline is more or less a junk drawer of all the different philosophies with no clear directive as to a consensus. So when you read this guideline, keep this in mind. What's important is what they all agree on. That's it. That's it for the test. Now, with these guidelines, what I've done is I've created worksheets that have the meat of the document. What is the montage? What is the active electrode, reference electrode? What's the polarity? Now, when we talk about the generator, there aren't questions so much on basic anatomy. What there are questions on is correlative neuroanatomy and neurophysiology. So it won't necessarily ask you which part of the brain the middle cerebral artery perfuses, but rather it would say you have infarction of the left middle cerebral artery. What would you expect to see on your SSEP? And obviously here, looking at all these different generators and the vasculature that subserves them, it's clear it would affect the N20. Now, next are the filter settings, which we're going to call band pass or bandwidth. So when we look at this band pass, you'll notice that there are two different recommendations, one for REPT and one for CNIM. Now, REPT, you just need to commit to memory the settings for the clinical environment listed under REPT. For CNIM, you must be familiar with all the REPT and all the CNIM guidelines. So everything on this page. Now, it's probably true for all of us that you'll look at these recommendations and say, well, Rebecca, we don't do that montage. We don't do that. We don't call that peak by that name. And that's okay. But I want you to know for the exam, the only answers that are going to be correct are material out of the obligate worksheets. And I will tell you there are probably 25 to 35 questions derived exclusively from the guidelines, derived exclusively from the obligate worksheets. And then you have your settings down here for your stimulator. Again, everything on this page is critical. So CNIM candidates need to know everything on these worksheets, to be clear. Now, I've also included a picture of the evoked potential from the guidelines in the obligate worksheet. And as you look at these obligate peaks, the peaks that have to be there in order to do an interpretation, it's important that you have the ability to answer several questions about each and every peak. So the list of questions that I want you to address as you're analyzing this data is first, what is the obligate peak name? So if they're pointing to a specific waveform, what is the name of that waveform? And then secondly, what is the active electrode in that channel? Which one electrode is responsible for eliciting that peak? What is the polarity and mean latency of that peak? Now with SSEP, unlike bears and visuals, with SSEP, it's very easy. The letter in the obligate peak name, like N20, tells you that's a negative peak. The number 20 is indeed the mean latency you'd expect to see that peak in the normal population. And then number 4, be able to identify the generator and which vessel serves to perfuse that part of the brain where the generator is. And then which, if any, anesthetics affect the peak and in which manner. This is an upper SEP. So this question, this anesthetic question, is for CNIM only. So of course it's cortical only. Only the waveform identified by the letter A would be affected. What would change with a cold or ischemic arm and leg? How would the data look different? What would be most affected by a decrease in stim intensity? Which one peak? And of course, that would be your ERBS point. So for upper SEP, lower SEP, and BEARS, brainstem auditory evoked response, you need to be able to answer all these questions for every obligate peak. And then for REPT, you also need to be familiar with the same information for the visual evoked potential. I've created these worksheets in 2 ways. In one format, all the answers exist. And then there'll be a second worksheet that doesn't have any information on it. And that allows you to print that off 100 times and just rote fill it in to memorize all of the information that's necessary for the exam. This year, recently, they published a new infection prevention article. So there now exist 2 copies of this document. One is copyright 2020, one is copyright 2013. What's important for you to know, if you're sitting for your test in 2020, you must study the 2013 document. Now, if you reach out to me via email, I will send you both. I think I will send you both, but know that the most important one to commit to memory for the test will be the 2013 one, unless you're sitting in 2021. Another article that I'd like to share with you is Up and Down the Spinal Cord, Interoperative Monitoring of Sensory and Motor Spinal Cord Pathways. Now this is an IOM article, but it's helpful also on the EP exam. So just because it says IOM, I wouldn't exclude it from my study materials for EP. So the first concept that they talk about in there is the influence of intensity of stimulation on your peak amplitudes. So with cortical peaks reach their maximum amplitude at motor threshold. So if I'm doing an upper SSEP, I see that thumb twitching or those pinky fingers twitching, whether you're doing median or ulnar, I see them twitching at about 8 to 10 milliamps. So at whatever point you start to see that motor impulse is the point at which you would expect your cortical to max out on amplitude. All of the other peaks, however, increase in amplitude. Your subcorticals and your peripheral peak increase in amplitude as you increase the stim. And this is great because it allows us in the operating room to validate supramaximal stimulation. In this article, it also discusses the concept of neurotoxicity. Now, neurotoxicity is functional damage to tissue, and does it affect stimulator or recording electrodes? It affects stimulating electrodes, and it is not subdermal electrodes like we use for stimulation at the wrist and foot, but rather it's in-field electrodes that get placed on the cord for stimulation. So both REPT and CNIM have to know the details of bullet point number 1 here. Only CNIMs have to be familiar with neurotoxicity. This is only for CNIM. There is a book written by Rodacek and Russell that dedicates a chapter to quantitative EEG in the OR, or computerized EEG. And you should know for these different formats, CSA, DSA, spectral edge frequency, you should know what is on the x-axis, what is on the y-axis, as well as what's the function of that graph, what does it tell us? And on page 84 of this chapter, there's a detailed description of each of these words. I have it here on this slide, but I can send you the actual page that gives you a good delineation for each different display format of QEEG. Next, I've created 3 worksheets, 3 more worksheet sets, because they're each about 3 or 4 pages long, that talk about numbers to know, graphs to know, and terms. Now, there are some concepts that you really have to have a good understanding of in order to answer a question. And then there are other concepts that I just want you to memorize the number. So for instance, down here, the differential impedance of the amplifier. Do you guys know what that means? I sure don't. I don't think it matters, but it's on the test. It's in the candidate handbook because it's in the guidelines. Now, with any numeric question, it's critical to memorize not just the number, but also the unit. They might have, for this question, they might have mega ohms, microvolts, milliamps, megawatts, but the number 100. So as you're memorizing your numeric values, pay special attention to the unit. And then next, pay attention to the reference sign. So this says it has to be equal to or greater than 100 megohms. So they might have one choice, exactly 100 megohms. They might have one choice, less than 100 megohms. They might have another choice, greater than. So know your number, know your unit, know your sign. I've created another worksheet called graphs to know. So there are several different graphs that might come up on the exam. And again, this is just a snippet. It's a snippet of that worksheet. That worksheet is many pages long, but what you should be familiar with is what is on the x-axis, what is on the y-axis, and then what does it tell us? What function does it serve? And then lastly, how would I use that? How would I use that in my clinical practice? And then math for the exam. So I don't know if you like math. I hate math. Don't most people hate math? Um, but I have interacted with students where they say, I'm just gonna take my chances with the math. I don't like it, I'm not gonna do it. But I will tell you this, students don't fail by 30 points. They don't fail by 15 points. The most common report I get is they failed by 2 or 3. So don't let math be the thing that takes you down. Know your math. And that's why I made this worksheet. Now for CNIM only, there is an article called Neurophysiological Monitoring, a tool for neurosurgery. It's a wonderful, like big scheme of things article. And I recommend that you read it. Now they talk about something, they use some terminology in there that you might see on the test called EMG soft sounds. And I have never seen that language anywhere else except in this article. So I recommend it highly if you're taking the test. And then I can send you also a muscle database talking about what's the muscle, what's the root innervation, what is the function of that muscle, but very helpful on the test. For CNIM, there are a couple go-tos for what we really talk about when we talk about you're taking this test, who's best to study. It's really important to know what language are they going to use. Like that zebra on Madagascar movie when he goes, "Now you're speaking my crackety lackety language." That's what these articles do. They use the language of the exam. And the very, very, very best reference for anesthesia is Dr. Todd Sloan. And I can send you his protocols for IOM if you hit me up with an email. Pseudocholinesterase deficiency, I have an article on that as well, but it has to do with the way that patients with this very specific genetic disease, the way that they metabolize muscle relaxant. So this is a patient who could be intubated with sucks, and 20 minutes later, when we expect to start doing our motors and our EMG, we don't have anything because they can't metabolize it off body. And in fact, can end up being intubated post-surgically with succinylcholine, with sucks, which is the most rapidly metabolized muscle relaxant. And then the other article that I highly recommend everybody read is an article written by Walt Benozzi on anesthetic and metabolic effects. And what I like about that article is it not only talks about the medication, but it also talks about vitals. At what point would temperature make a difference? At what point would cerebral blood flow have an impact on our responses? So I highly recommend these articles for those taking their CNIM exam. The documents that recommend how we handle substances like collodion, acetone, and sodium hypochlorite, which is bleach, the documents that describe how you protect yourself and your patient when you're using these substances used to be called MSDS, Material Safety Data Sheet, but now they're called SDS. And they just tell you, do you have to wear a mask? And the answer is yes, yes, and yes. Do you have to wear an eye shield? Again, yes, yes, and yes. Do you have to wear gloves? Yes. What happens if it gets in your eye? what happens if it irritates a patient's skin. There are recommended flush times. There are recommendations for what you do in the face of a fire breaking out. Do you put water on it? Do you not? And then lastly, if the patient were to swallow any of these substances, do you induce vomiting or not? And it's very different between these three. And probably the most radically different one is collodion. You do not induce vomiting if they ingest collodion. It's like Mexican food. It would burn going in, burn coming out. So they stabilize it in the tummy. And then if a fire breaks out with collodion and you put water on it, just like a grease fire on the stove, it doesn't help. It just makes the fire bigger. And pay attention. The easiest questions to answer are questions involving the duration of time that you flush skin and eye. So for acetone, for collodion, it doesn't give a time. It just says flush if you have irritation of the skin or eye. For hypochlorite, which is sodium hypochlorite, which is bleach, that recommends 15 minutes on everything. 15 minutes if it's in the eye, 15 minutes if it's on the skin. Of course, you have to be familiar with the health HIPAA, all the HIPAA rulings. When can you give patient records to someone? You have to be familiar with the electrical safety guidelines. Now, two of the biggies in electrical safety have to do, number one, with microshock. That's when a patient has an indwelling device. That device, pacemaker, acts like a magnet to any current in the patient's body, and it can deactivate or deprogram the device. So read everything you can about microshock. And then the second concept that is heavily tested is the concept of grounding. So we only ever put one ground on a patient, so we don't introduce a ground loop. You also have to be familiar with the national patient safety goals. And that has to do with making sure we have the right patient, the correct patient, the correct surgery, the correct site or side of surgery. For the CNIMs out there, if you aren't strong in auditory evoked potential monitoring or cranial nerve monitoring during craniotomy, the very best reference is Augie Moeller's book. And Augie's a scientist. He's a PhD audiologist, but he's a scientist. And when you read through his chapter, you'll see that he talks about a lot of special electrodes. He talks about a plate electrode placed on the floor of the fourth ventricle, a wick electrode placed on the exposed eighth nerve. None of that is on the test. That's research driven, not minimal competencies like Abbott is testing you on. Cranial nerves. You have to know your cranial nerves by name, by number, by function. Where do you put the needles? How long after stimulation would you expect to see a CMAP? If you email me, I will let you know if I'm doing any free power sessions. Power sessions are brief lectures on a special topic that involves the exam. And it usually comes from one of my students saying, Rebecca, I don't understand instrumentation. Can you do a lecture on that? So where do we start? The first thing I would do is read through your guidelines once, then print your obligate worksheets and memorize this week. Get on, we're in a special time right now where we are low on caseload, low on patient load. This would be the perfect time to sit down and just memorize all of your obligate worksheets. And then once you've memorized your obligates, print the 3 worksheets, numbers, graphs, and math, and memorize that. And then read up and down the spinal cord, infection control, anesthesia for CNIMs only, electrical safety, the 2 Augie Moeller chapters. And then I also recommend you read or you buy the Aberrant ASAP modules. That is a mock exam that very closely resembles the real exam that you're going to take. Excellent, best study aid. Right now, exam centers have been suspended until May 18th. And of course, May 18th may or may not be the day they open back up again, but right now it's not possible to take the exam. When you take your exam, you can take your exam anytime. And when you're finished with your test, it will produce your results. It'll spit out a pass or a fail, not scored, but just say you passed or you failed. And then a couple weeks later, you'll get your actual results. It's really important as you start your board prep journey to read the candidate handbook, to go to the aberrant.org website, download it, and read the candidate handbook for both CNIM and REPT. Now, there are a couple references that are critical as you prepare for your exam. So first, of course, the guidelines. Now, what I've done is I've crossed off references I think are not the most important, not necessary. CIAPA looks like CHIAPA. CHIAPA, Evoke Potentials in Clinical Medicine. That's essential for disease correlates. That's the only thing I want you to study out of there. Okay, I live in Florida, and there are some sandhill cranes out back of my house right now. So I hope that noise isn't coming across on the podcast. So the other reference that I think is really excellent is Dr. Spellman's Evoke Potential Primer. Now, what happened at some point, Spellman had passed and Mizoulis rewrote it, and it isn't so good. The older version is the better version. Of course, you have to read your infection prevention. And then another great book is the Yamada and Ming Practical Guide for Clinical Neurophysiologic Testing. Great books. You can get them on Amazon. For CNIM, of course, guidelines. For CNIM, they also recommend you read one of 2 operating room procedure books. One is the AORN, one is Berry and Cohn's operating room procedure, one is Alexander's care of the patient in surgery. And what I want to say about there is only maybe 5 questions from those. And it really has to do with information that you were trained with in the OR, like how far do you have to stay from the sterile field? What part of the surgeon's gown are sterile? Really, it's just a small subset. These are 600 to 800 page books. Really kind of a waste of money. And then there are several IOM books that are great, but they all kind of duplicate each other. So the Galloway book, the Hussein book, the Mark Newer book for the OR exam, they're all great. They're all great. Not one is better than the other. I would say if I could only afford to buy one, I would buy Atif Hussein's book because it is practical and not researchy. Of course, we already talked about Moeller's book. It's an essential read, essential. Even if you do craniotomy every day, it's a great reference. I like the way Dr. Moeller references his questions. It's just very easy read. And again, Newer, I maybe would buy Atif Hussein's book. If you could afford both, great. And then a very special book for CNIM only, for CNIM, is the Mariella Simon book. And what she's internationally known for is EEG in the OR. So if you don't have great intimacy with EEG in the OR, she's the great read. Of course, this doesn't apply to the REPT candidates. And do try to find a copy of the real Spellman's primer. It's gold. For the CNIM exam, a concise guide to interoperative monitoring is, I always call it IOM for Dummies, because it's very simply written. Now, in any of these textbooks, if you find a discrepancy between the guidelines and these books, always go with the guidelines. The answers on the exam will always be guideline based. The ABRT self-assessment modules. So this is an EP and CNIM practice test. What I love about it is this happens to be the summary screen from the EEG exam, but it's very similar on the EP. It has all these tabs. It's hundreds and hundreds of questions that are absolutely similar to those you're going to have on the test. It's $69.99 for a 1 month and $154.97 for 3 months. I think it makes sense to buy it twice for a month each, one at the beginning of your studying time and one then at the end. Once you get your certification, it's really important to stay on top of it. At the end of 5 years, you're going to submit 50 credit hours to renew, and it's $100, but it's really important. If you fail to catch an email and it's your renewal and you expire, you are treated like a new candidate, which means you have to do your 150 cases again and provide documentation for your CPR. There are a lot of people, like myself, for instance, I go in the OR. I don't go in the OR as the primary care provider. I teach in the OR. So what it means, if I were to expire, I don't qualify to take it again. I don't qualify, I don't have the cases. So stay on top of it. Test taking 101. Every question on the exam will have 4 answers. 1 answer is right, of course. 1 answer is close, but no cigar. And 2 answers are wrong beyond wrong. So start by crossing off the wrong answers. Find the key word in each question. What is the question looking for? So in this question, select the anesthetic category known to have the greatest impact on interoperative monitoring. Does fluorine for sure impacts our monitoring, but it's not an anesthetic category. Nitrous oxide affects our waveforms for sure, but it's not an anesthetic category. So the answer here is halogenated agents. I had always believed that changing an answer was a bad idea, but study after study shows that it's okay to change an answer. So recently, the Professional Testing Corporation changed the test people from PSI laser grade to Prometrics. So that's the only thing that's different. It's given any time. What I would recommend you do, I would really recommend you take the test a weekday, because if anything goes wrong, you can call ABRT. ABRT isn't in the office on weekends. So take your test, schedule your test during the week, so that if you don't get a tape measure or the scratch paper, something, you can call ABRT and get it fixed while you're still there. Again, this exam is based on the guidelines. And again, there are 4 interoperative guidelines. These are free on the ACNS website. I can send them to you. They're free on the website, but do pay attention in case they upgrade anything. I don't think they will, just because they don't do it very often. But these are the clinical guidelines. If you're taking the REPT exam, these are the guidelines that you have to be familiar with. Thank you so much for your time today. And I hope to meet you in the future and give you an opportunity to have what I call the whole Rebecca, to have me in front of you, asking you questions and interacting with you. Have a wonderful day and enjoy the rest of the conference.